Good morning. I'm pleased to present this talk on LV systolic function. The objectives of this talk are to discuss the value of LV systolic function assessment, to review LV myocardial architecture and how it relates to LV systolic function, and to describe methods for assessing LV systolic function with a focus on 2D and 3D LVEF and 2D speckle tracking strain. Assessment of LV systolic function has demonstrated prognostic value in a variety of disease processes as listed on this slide. This is why assessment of LV systolic function is the most common indication for an echocardiogram in most laboratories. A variety of methods have been used to assess LV systolic function. The Tycho's and Canonian methods are two older methods using linear dimensions to estimate volumes. They're no longer recommended in the guidelines for use. Rate of ventricular pressure rise and LVOT stroke volume are methods that can confirm your assessment, but they have their weaknesses and are not quite recommended as the initial assessment methods. I'm going to focus most of my talk on biplane method of DISC, which is recommended for 2D data, 3D volumes, which is for 3D data, and LV strain. Currently, the biplane DISC summation method is recommended for 2D echocardiographic data. A stack of elliptical discs covering the LV are calculated using contours from the apical 2 and 4 chamber views. These discs are then summed to determine the LV and systolic and diastolic volumes and to calculate ejection fraction. As you can see from the methodology, this is why biplane LV volumes are not an average of the volumes from the 2 and 4 chamber views. Keys to successfully using this method include focusing on optimizing the endocardial definition during image acquisition and identification of the true LV apex and ensuring that there is no foreshortening. One source of variability and inaccuracies in this method is the placement of the endocardial border. Ideally, it should be placed at the compacted, non-compacted myocardial border. Quality improvement initiatives should be performed in laboratories to ensure consistency within and between interpreters. The use of semi and fully automated programs will reduce variability and improve accuracies. Normal 2D LV volume and ejection fraction ranges are provided in the 2015 guidelines. These values were derived by combining data from seven different databases. There was no core lab involved in these studies. I also want to point out that the partition values for mild, moderate, and severely dilated are provided. However, these are expert-based rather than outcomes-based. I suspect that the next iteration of the guidelines will have cutoff values that are different based on this WACE study. WACE was a multi-center, multi-country study sponsored by the American Society of Echo to generate normal echo values. It involved over 2,000 participants. All the echocardiograms were analyzed in two core labs. In this table, there is the LV end diastolic and end systolic volumes and ejection fraction data for males and females from the WACE data. As you can see, LV dimensions and volumes were larger in males than in females, while females had higher LVEFs. Also provided are the cutoff values in the 2015 guidelines, and you can see that the upper limits of normal values for the volumes are larger than that in the current guidelines and will likely trend upward in the next guidelines, as well as the range for ejection fraction is narrower, and that will probably also be changed. The WACE study also provided information on differences among races and nationalities. Here I've included a figure with each country in the study represented as a circle. The areas indicate that there's a significant difference between the values between these two countries. The base of the arrow is the larger value and the tip of the arrow represents the smaller. Here for both males and females, many countries had much larger LV and diastolic volumes indexed compared to those in India. On the right, I've given you the male and female breakdown for LV and systolic volumes indexed and diastolic volume index and ejection fractions. And across the bottom, you can see it by country as well as by white, black, or Asian race. The brown shaded area is the global WACE upper and lower limits of normal. The blue bars indicate the current guidelines upper and lower limits of normal. As you can see, that there are no differences in ejection fraction across the countries or by race. However, there are differences in volumes, with dimensions of volumes being similar for patients of white and black race and smaller for Asians and Mexican. And there are also significant national variability. I haven't shown you the national variations within the same race, but overall nationality likely should be considered when defining ranges of normal LV volumes. Overall, to summarize, the biplane dissummation method, the strengths are that it corrects for shape distortions. There are fewer geometric assumptions made using this method compared to linear dimensions. Weaknesses include the fact that image foreshortening can render the measurements inaccurate. It's also blinded to regional abnormalities not included in the 2 or 4 chamber views, and endocardial dropout can increase the variability due to the endocardial border placement. Ultrasound contrast should be used when 2 contiguous LV endocardial segments are poorly visualized in the apical views. This allows you to better see the endocardial border and provide you a way of measuring the LV volumes and ejection fraction. Because you can see that compacted, non-compacted border better, LV volumes tend to be larger when used with contrast. However, normal values have not been established yet, which makes it tricky to know what the values mean. Now, in laboratories with experience in 3D and in patients with images good enough for 3D data acquisition, the guidelines currently recommend that 3D volumes and ejection fractions be reported. When I think of 3D, I'm actually thinking of true volumetric analysis, although you can use 3D to guide an improved biplane measurement. But mainly when people talk about 3D, they're talking about this true volumetric, where all the walls of the left ventricle are tracked and accounted for in the volume and ejection fraction. Similar to 2D echocardiography, dataset optimization is important for acquiring reliable volume measurements. You want to use the multiplane view to ensure that the entire left ventricle is within your 3D pyramid. You also want to make sure that the endocardial border definition is good in all views and that there is no dropout in systole or diastole. People generally recommend slightly overgaining the data set to ensure that you have an analyzable data set. It is also sometimes recommended that you slightly overgain the apex and decrease the gains in the basal segments to improve your quality. Your volume rates for your 3D data sets should be ideally over 20 volumes per second, although over 15 is acceptable. The reason you want to do this is you want to make sure that you don't miss the true end diastole or the true end systolic volumes, as these will affect your ejection fraction measurements. One of the problems is when you narrow your 3D pyramid to ensure a higher volume rate, you may have dropout, as you can see here, of the apical segments. One solution to this is to use the virtual apex options on some machines, which means that the beam, instead of starting at the piezoelectric array, is in the probe, and so you end up with a wider base, and this lets you get more of your LV within the pyramid without getting a large pyramid. For some data sets, you may not be able to do that, or machines you may not be able to do that, and so you may have to go to multi-beat acquisitions or high volume rate modes to achieve this. Normal 3D reference values aren't actually specifically provided in the guidelines. What's given is an actual table summarizing findings, and partly this is because there are a limited number of patients and a limited number of studies. I expect that this will be addressed as there was a 3D sub-study performed as part of WACE, and so there will be a large number of values that could be provided for the 3D data. Again, similar to 2D, semi and fully automated methods are available for analyzing 3D data. Several meta-analyses have been performed. The most recent one was published in JACE in 2019. This study showed that fully automated methods are actually more accurate compared to MRI gold standard than semi-automated methods. Additionally, they have less variability. One of the things they did sort of find a signal for is that there may actually be differences in vendors, and so for serial studies, the patient should undergo analysis by the same vendor platform. Overall, to summarize, the advantages of 3D volumetric analysis is that it avoids image foreshortening because the entire ventricle is in the data set. There's no geometric assumptions made because all the walls are seen. As serial studies have shown, that is more accurate. And it also has better prognostic value compared to 2D LVEF. Now, part of the problems is that in patients with large hearts, the temporal resolution is much lower because of bigger data sets, though technological improvements should help with that. And we don't have large normal value studies available to date. Now I'm going to focus on myocardial deformation imaging. There are two methods that can do this, tissue Doppler as well as speckle tracking. I'm going to focus on speckle tracking for the rest of this talk. This is a nice paper published in 2018 summarizing the additional prognostic value of LV strain analysis on top of LV function analysis in different disease processes. Now, in order to understand strain, we have to understand the myocardial architecture. On the right, you can see two images. The top is a cartoon and the bottom is a desiccated heart, and you can see that the fibers are oriented in an oblique helical pattern, and on the endocardial or subendocardial surface there's a right-handed helix, and it becomes a left-handed helix in the subepicardial region. This sort of results in a predominantly clockwise motion at the base of the LV and a counterclockwise motion at the apex. This opposing motion of the LV base and apex results in a ringing-like motion during LV systole. Now, if you take a slice of the myocardial wall, you can see that most of the myocardial fibers are circumferential, and the ratio of circumferential to longitudinal fibers is about 10:1. Most of the longitudinal fibers are in the subendocardium, most of the circumferential in the mid-myocardium, and oblique fibers are mostly located in the subepicardium. Now, when we're tracking strain, we're using speckles. Now, these speckles are formed from constructive and destructive interference of ultrasound backscatter from structures smaller than the ultrasound wavelengths. Generally, noise is filtered out, and stable speckles or kernels are kept in the image. Now, how is speckle tracking performed? Usually the block method is the most common method that's used. What happens is there's a region of interest and speckles or features are identified within that block. Then blocks are sampled elsewhere, and these speckles that match the original block as most as possible is considered where the speckles have moved. Once you know where the speckles have moved to, then you can actually calculate strain. Now, strain is a calculation, and it's the fractional change in length or area or volume. How it's calculated is usually the final length minus the original length over the original length. Now, this calculation is important because it explains why longitudinal and circumferential strain are negative values versus radial strain is a positive value. Both longitudinal and circumferential strain result in myocardial shortening, and so the end final length is smaller than the original length, and so that's why you get a negative value. Most clinically useful strain is longitudinal strain, and the remainder of this talk will focus on that. You have to understand how your lab is reporting values because they may be reporting the calculated value, which would be a negative number, or they may be reporting an absolute value, and the interpretation will be different. So normal strain is around 20%. If you have a decrease in strain and it becomes abnormal, it will go down to minus 10%. And so if you have a strain value that is greater than normal or more negative, which is minus 22, that is still within the normal range. Now, typically when we acquire images for strain analysis in our lab, we acquire them at the end of the study. This way we ensure that the heart rate is within 10 beats per minute range for all the images because this can affect your strain values. We try to do our best to acquire non-foreshortened views and we want to make sure that the endocardial deafening is as best as it can be throughout the cardiac cycle. If you look at the series of 3 images on the left, you can see that there's a bit of diastolic dropout in the mid to apical anterior wall in that 2-chamber view. If you look at the second image from the right, you can see that that would be an analyzable picture. However, there is artifact at the apex, and so that segment would likely have to be excluded during analysis if it wasn't tracking properly. And the image on the farthest right, you can see that would not be an analyzable image. The other thing you want to make sure is that your frame rate is, and depending on what you read, between 50 to 60 to 100 hertz, because this can affect your strain values. Semi and fully automated methods are available for strain analysis. This is a nice paper published in 2018 summarizing with videos as well as images the different vendor platforms that are available out there, and I've added this reference in for you. Now, when you do the analysis, you actually have to standardize contour placement and region of interest if you want to make sure that you're at the mitral valve leaflet insertion points and you're not in the left atrium. For the basal points of your region of interest, you also want to make sure that you are not tracking the papillary muscle, as you can see on this movie over there. And you want to make sure your region of interest is not too thin, in which case then you're getting mainly the longitudinal fibers and you'll overestimate your strain, and you're not too wide because then you'll underestimate it. You have to also check that your timing of end diastole and systole is correct, as this will affect your measurements, and this is especially true in patients with conduction delay. And lastly, when you're using semi or fully automated programs, to increase reproducibility, we generally encourage that the sonographers minimize the editing that they do. Most people recommend that if 2 or more segments in a single view are not trackable, then global longitudinal strain should not be calculated for that view. There is variability among those different software packages on how much a data set could be tracked. Here, the same patients were imaged by all the different vendors, and you can see using the same data set that there's variability in the tracking and how much has to be excluded. If you're training to learn how to do strain, it's recommended that you have to analyze more than 50 cases. There's a nice study here showing that whoever is learning to do strain, once you get over 50 cases, your correlation between other readers increases. You want to be able to pick up the fact that the borders are where it should be. Here's a case where the border is placed almost too close and is tracking the epicardial surface. And then here on this image, it's fixed. And you see the difference in terms of the strain values that are provided. This slide just shows the different formats that data will be presented. Usually there's a color-coded region of interest that lets you check tracking as well as contour placement. Here the peak systolic strain values are presented, as well as the regional strain curves. And there is a heat map showing the curved anatomical M mode. Additionally, there's a bullseye that can be shown showing the regional changes. Generally, the guidelines say that a value less than an absolute value less than 20% is abnormal. However, others have said that absolute values less than 16% are abnormal and greater than 18% are normal. But then this leaves this lower normal range of between 16 to 18%, which we don't know what to do. Waist did do strain analysis, and you can see that women tend to have higher global longitudinal strain values. And once again, though, you can see that in many countries, the lower limits of normal fell out of what the average were. And so interpretation of lower limits of normal should be interpreted with caution. One of the limitations of strain will depend on which generation or which version of the software you're using. But going back to that inter-vendor comparison that was done, you can see that there is significant variability in global longitudinal strain, and there's also significant inter and intra-observer variability depending on the package that you're using. Now, standardization of definitions for global longitudinal strain have been performed, and studies have demonstrated that after the standardization, the variability between vendors and within a vendors have actually improved. This can't be said about regional longitudinal strain. Studies have demonstrated that there's still significant differences in regional strain measurements, and this also extends to reproducibility and variability. So the bottom line on segmental or regional longitudinal strain is that there's significant intervendor bias that exists, there's high variability, and single segmental strain values should be used with caution. That being said, there is a role for pattern analysis, and the most common one we recognize now is this amyloid pattern with apo-sparing of strain. Contrast has been used to enhance strain analysis. This study showed reasonable results, although it's probably not ready for routine use at this time. Overall, 2D tracking global longitudinal strain is very 3D echocardiography can address some of these weaknesses. However, it must be noted that this is still a research tool and that there are differences among the vendors, and so it's probably not yet ready for real-time use. Lastly, I want to discuss the relationship between LV ejection fraction and strain. We've kind of talked about them as separate entities, and then there's this concept that that strain is picking up submyocardial abnormalities. What I do want to say is that there is a linear relationship between LV ejection fraction and strain. As you can see that as strain, as this absolute strain value increases, so does LV ejection fraction. And sort of a rule of thumb is that sometimes you can multiply from this the strain by 3 to get a rough estimate of your ejection fraction. Now, what about patients with quote-unquote preserved ejection fraction? You can see that even in patients with preserved ejection fraction, there is a reduction in global and circumferential strain. Now, one of these confusing concepts is how can you have normal ejection fraction with abnormal myocardial function? This paper tried to address that, and what they did was they both used echocardiographic data as well as mathematical modeling. And what they found that you can have a preservation in ejection fraction in ventricles that have thick walls or reduced end diastolic volumes, even if your global longitudinal strain and circumferential strain are reduced. And in some cases, the reduced longitudinal shortening or longitudinal strain can be compensated as it contributes less to LV ejection fraction than circumferential shortening. And so sometimes there's a compensation by circumferential strain. In summary, 3D LVEF should be reported over 2D LVEF when expertise is available. 2D speckle tracking global longitudinal strain should be performed routinely when indicated. Care should be taken for both 2D and 3D volumetric and strain analysis during image acquisition. Training is needed to standardize analysis of ejection fraction and strain. Semi and fully automated methods will help with routine reporting and improving reproducibility. One of the things that you have to be aware of is possible intervendor differences, and at this time it's probably recommended to use the same vendor for serial analysis. Thank you.